I think I'm going to bring the talk slightly different to all the talks you've had maybe before, a little bit more in line with Jim's, but a little bit less on the specifics of the therapies that we use, more how I see that I think as a heart failure cardiologist, and how I know that I'm very different from some of my cardiology colleagues, and how our cardiology colleagues here in the quaternary centres are very different from our cardiology colleagues in other centres. So there are a lot of gaps. And then I also wanted to touch on how we went about changing our care for patients with advanced heart failure in Boston, and how that came about and what difference it made. So we know that we have to concentrate efforts at every single stage of heart failure. Those who are at risk, who have no symptoms, those who have structural heart disease but yet have no symptoms, we kind of don't know who these people are yet because they've no services directed at them. This is the point where we do a super job. Generally, every big hospital in Ireland has a heart failure unit. We are very good at saying, at least on paper, that we have a multidisciplinary team that care for these patients in the heart failure unit in the outpatient setting. We're very good at medical management because we have a lot of evidence base for what we're doing now. We are common referrers for angiography and therefore for revascularization. And increasingly, we're meeting international kind of uptake levels for CRT and ICD. But what is little less global in Ireland is the advanced heart failure care. To get good advanced heart failure care, you generally tend to need to be in a quaternary centre. And similarly then, as we've heard already, levels of referral for patients with advanced heart failure to the hospice services in Ireland are really quite low and don't meet international standards. So what are the current services? Well, we do have some preventative services in Ireland. Through Vincent's, that works through Wicklow, Wexford and the Midlands, they have a Stop HF programme which looks at people with high risk factors for developing heart failure. So actually we are trying to start at prevention. Like I said, we have a great symptomatic heart failure service, and then here in Dublin we have a great heart failure clinic in every of the major hospitals. And then for advanced heart failure care, that's for patients who are being considered for VADs, that's ventricular assist devices, and for cardiac transplant, really the matter is the site. But you will note there, at no point do I say anything about palliation. We have no formal linked services between heart failure and palliation, except for in the Mater Hospital, which does the advanced care. Now, the advanced care and palliation are obviously a very good mix because these patients have no other option but to be considered for these advanced therapies. So it's that or death. So clearly palliation is always going to be thought about at that time. But there's an argument that there are a huge amount of population out there who actually would benefit a lot better from palliative care services, either directly or indirectly, that we just don't have any joined up thinking about. So let's be frank. The usual path to the end of life care in Ireland is that when somebody has a new diagnosis of heart failure, we talk about the risk of death. When we're considering somebody for an ICD, we talk about why we're putting it in, because there is a risk of sudden cardiac death and it could potentially save their life. And then there tends to be excellent collaborative medical care in the heart failure clinic, combined with the GP frequently, and the talk of death really isn't ever raised again. And then between hospitalizations for heart failure, patients tend to lead fairly full and relatively symptom-free lives because it is a waxing and waning disease. And then death is generally next raised at the terminal hospitalization, and often hours or even minutes before death, and an urgent palliative care consult. And I've worked in Ireland for a very long time, and I've often worked away as well, and this is a common phenomenon not only in the peripheral centres that don't possibly have access to specialist care, but also in our quaternary centres. And perhaps it's because cardiology might seem like one specialty to the outside world, but within cardiology, I'm known as the touchy-feely cardiologist because I do heart failure and I like to talk to people about their values and what they would like for their end of life, whereas I have other cardiology colleagues who I would consider the surgeons of cardiology, who like to slice and put things in and make things look pretty in pictures, but do not want to have those conversations because they are thorny. So it does matter in who's caring for the patient. And often the clinical team who's caring for the patient will make an assumption about what the patient might want. But it is an assumption and there's no discussion, and I'll go into that in detail later. So you've seen this slide a lot today. Fliss gave a lovely diagram where we should be combining more of palliative care in this diagram, but this is usually how the path takes. Patient gets diagnosed with heart failure. They then have an indeterminate course where they're at a plateau, and then they have a dip, and then suddenly a worse dip. And finding that yellow blob, as she talked about this morning, of that point of transition where we need to be thinking about palliative care is very difficult. I'll give you some data on that later. And generally palliative care, like I say, tends to be introduced just before the end. We need to have a little bit of thinking that it needs to go back to the earlier stages in the diagnosis of heart failure. And again, that's not necessarily that I need a specialist palliative care consultant with me in clinic at the time of diagnosis and treatment for early stage heart failure, but we need to certainly be thinking about it more. So for you guys in palliative care, this is not a new concept, but in cardiology, I'm sad to say, it remains a fairly new concept in that many still think palliative care means end of life. And in 2002, the WHO new definition came out that it says early in the illness, palliative care should be provided in conjunction with other therapies that are intended to prolong life. And that's just really not known, sadly, in the medical world. But it's done because there are multiple domains of distress in the patient's life that medicines alone and up-titrating medical therapy is probably not quite reaching. Communication is probably the big key here, and I'll give a little talk on some of the thinking behind how that is best done. And again, it is something that is often lacking in busy clinics that do not have the resources or specialists who are trained in heart failure care. So why do patients get their symptoms? Well, for a multiplicity of reasons, but there are many physical reasons behind the inflammatory process, the pro-inflammatory process of heart failure as to why people get their symptoms. But similarly, as has been said before, frailty and multiple comorbidities, the average amount of comorbidities for any heart failure patient is 4. They're very frequent. And so it is a very difficult disease condition to understand. And so while people might think that they're good at heart failure, perhaps that's a surface level of competency, and maybe I agree, we do need more specialists working in the field. But when we look at this, this is a lovely diagram about what symptom is caused by what physiological change. And I think as physicians, we do very well with dyspnea. Oh, you've got dyspnea. I know, I can do something about that. Here, I'm going to measure your BMP, titrate your diuretics, titrate your afterload reduction. But when it comes to anxiety and depression, gosh, I'm really not so sure what to do about that. Fatigue, there's nothing I can do about that frequently, so I tend to just ignore it. And anorexia and cachexia anorexia tends not to be asked about, and cachexia is often only noticed at its very terminal stages. So I would say that while many of our heart failure units work as a multidisciplinary team, really there's just a heart failure nurse and a consultant, but there isn't like a dietitian available in every clinic. There isn't a social worker available in every there isn't a psychologist available in every clinic. Luckily, I'm moving to Vincent's that has a very replete heart failure unit, but not all are as lucky as that. So while we talk a lot about really having optimal care for heart failure patients, I'm just not sure that all of our clinics manage to do that. And so the psychosocial effects are often overlooked by busy medical teams, but we do need multiple disciplines to address distress from symptoms, but also the other aspects of illness. So what do we need to know about discussions about death? Well, first of all, when we're talking to patients with a new diagnosis, the focus of our treatment is to improve their function and to defer their death. But when we're having these discussions, we need to have the difficult discussion now, because it will simplify difficult discussions later on. Patients will often ask, well, how long have I got? And the answer to that is, we do not know. It is uncertain. It is often a lot more uncertain than for many cancer diagnoses, as already been discussed eloquently this morning. But what patients need to know is they're at increased risk of sudden death, but also they could have a long, prolonged course of a waxing and waning illness. And they need to be prepared for both events happening. So oftentimes, if something happens unexpectedly, they need to have asked somebody who knows what their wishes are, should that happen. Obviously, we try to avoid that, but should it happen? But knowing that we're trying to defer death and that heart failure is life-limiting, sometimes actually helps patients actually be involved in their healthcare. So actually this difficult discussion turns into a tool for having patients involved in, actually, I'm going to watch my sodium, I'm going to weigh myself every day, I'm going to call the heart failure nurse if my weight goes up by so much. But it also helps them plan for the worst, because it still surprises me how many patients are being seen in busy cardiology clinics, and then when they come in with their terminal event in heart failure, me saying to them that I think this is the terminal event is the first time it's ever been mentioned, or it feels to the patient like it's the first time it's ever been mentioned. There is a white paper out in 2009 on heart failure which suggests that you talk about it at the time of diagnosis, at the time of an intervention, or if there's a sudden decline in status. But actually, recent data that was out just last year in JACC heart failure, when we look at a large American cohort of patients, very few patients have advanced directives, as we see frequently here in Ireland. And so Lynn Stevenson, who was the lady that I trained with in heart failure, seems to be one of the cardiologists internationally who is leading the field of, as discussed this morning, trying to bridge that gap between the two quite different specialties of palliative care and heart failure. So she frequently writes on how we best manage patients and help them to come from diagnosis to end-of-life care. And her suggestion, as always, is a very reasonable one. It's that decision-making is a process. It is not a point. It is not you have one discussion with the patient and you assume that decision lasts for the eternity of their diagnosis, because heart failure changes with time. So she's described a ladder of shared decision-making. So for example, you talk that an unexpected event can happen, recommend they get a healthcare proxy. And so here on the left, you've got the medical care providers. Yeah, and then on the right, you've got what the patient and family must do. So it is an ongoing iterative process where the physician has an input, the patient and family have an input, and at each visit, each person in this relationship has some work to do. So then you give some advice on general uncertainty regarding your health outcomes, and then the patient is given some time to consider what their preferences are about how they want to receive their information. As discussed, some patients do not want to know and want to totally defer that either to a family member or to the physician. What I'd say is, while that's important, again, this issue of consent, it has to be very patient-centered, and that may not be enough anymore to be patriarchal in your care of patients. But as the ladder goes on, it's representative of advancing disease. And so you need to have those what-if discussions down at the bottom of the ladder for bad things that are going to happen later on. So say, for example, a patient suddenly has class NYHA4 heart failure, they're not a transplant candidate, they're being maintained on inotropes. You need to say, well, what happens if you have a cardiac arrest? What happens? But actually, we need to be thinking about that earlier, before they're at the inotrope stage. Because again, it's easy to think about it when they're at the inotrope stage, but talking about it beforehand relieves a lot of anxiety for patients and their families, and actually makes that talk when they're on inotropes much easier and almost anticipated by the patient. And what I frequently see as well in patients that we're minding, we often have patients, this rotating door policy where patients come in, they're put on inotropes and diuretics, and they're sent home, and they're back in their inotropes and diuretics. And because we're not withdrawing treatment, as often happens in oncology when patients are palliative or at the end stages of their life, patients and frequently doctors don't realize that they're at the end stages of their life. So there is a lot of misperception out there in patients about what stage of their disease they're at, and that can all be altered by frequent revisited communication at each visit. So how Lynn phrases it is that if you have a yearly review with a patient and have them consider it like a flu vaccine visit, where it's not their usual medical care, but their discussion is, okay, it's now been a year since we last talked about what you might like, then at least it's put into their diary and it's something that they can expect, which is fantastic when you have the resources. But it is something that we should strive for. Lynn has looked a lot at time trade-off in chronic heart failure. So this concept where we look at a patient, they've been in hospital 5 times in the last year, they're on inotropes, their creatinine has gone from 100 to 350. We know that they're dying, so we're going to assume that they probably don't want resuscitation. So this was looking at the ESCAPE population, and the ESCAPE trial was a huge trial in heart failure in the 90s, and we have a huge amount of data and follow-up time from it. And what they did was they asked patients when they were initially hospitalized for heart failure and enrolled in the trial, you've 2 years. Would you trade any time of that 2 years to feel better, or would you continue to feel as bad as you are, but be able to live out your 2 years? And I don't know what you would think, but I would think, gosh, if I'm feeling awful, I might trade off some time so that I can feel better and have a better quality of life. And if I'm feeling reasonably okay, well then maybe I might not want to. And so there was a bimodal distribution. Half patients did not want to trade any time at all. They wanted to survive the 2 years. They didn't mind what symptoms they had. And then about a quarter wanted to trade all of their time to feel better. But then, a year subsequent, they were asked again. Now, half of them didn't change their mind, but half of them did. And so probably the time to ask them is maybe not during the initial hospitalization, but maybe at the discharge first follow-up visit or a month later. And what they found when they analysed the data in detail was that it did correlate directionally with symptoms and function and depression, but it was modest and it was not linear. But actually, those with the severe symptoms did not want to trade any time. They wanted time even though they felt very bad. And those with moderate symptoms would trade a considerable amount of time just to feel better, which was not my assumption. And maybe I'm different, but it certainly wasn't my assumption. And so our assumptions about patients' preferences based on their symptoms is probably not right. And then even within those groups of severe symptoms and moderate symptoms, then there were patients who were different to each other. So it does highlight the complexity of what we do, and so we do need further study to elucidate this, but it's just something that we shouldn't assume. So what happens at the end of life? Well, it's not easily predicted. In a large US study where we thought patients had about 6 months to live, the vast majority of them went on to live beyond that 6 months. And we have lots of prognostic models, as Jim was talking about earlier, but actually nurses' predictions are better than the prognostic models. And resuscitation, again, may no longer be required, but it is something that needs to be talked about. But you can imagine that if it's talked about in the outpatient setting with the heart failure consultant that they see all the time, it's probably going to be a more informed decision than in an acute decompensation to an outside medical centre that they do not know the provider. So it is something that we need to think about. I'm going to flick through a little bit here only because I have limited time. And so when I went over to the Brigham, it was about 2006. And at that time, hospice delivered heart failure treatments were few. When you think about what we give, yes, they gave ACE inhibitors, yes, they gave oxygen, that's great, but most of our palliative patients were on inotropes. And inotropes were not delivered at the time. CPAP was not delivered, and things like intravenous potassium, which we do to help supplement our diuretic therapy frequently, were not given, and it precluded admission in many instances. So how did the Brigham go about trying to bridge this gap? Well, they formed what's called supportive cardiology. They're obviously in the very lovely position of being in a big academic centre, Harvard supported, so lots of money, and they had a palliative care consultant whose primary interest was cardiology. She'd also done cardiology before palliative care. But what they did was they formalised a working relationship with palliative care where the palliative care consultant became an integral part of the heart failure team. The focus was on quality of life, not end of life, which for the Brigham was an empowering change and would be for, I think, most hospitals in Ireland. And they were involved early in the patient's course, not just to talk about preferences for end of life, but also to help them empower their decision making along the way. So, for example, TAVI, VAD, all of the things, all of the aggressive interventions that we do. So who and how did we do it? So all patients with advanced disease, so all of those patients in the red upper tiers that I showed in that first initial graph, anybody that we were considering for inotropes, VAD or transplant, they didn't have to be already at that stage, but those that were marching towards that stage. The palliative care consultant came on the ward rounds. They came on the heart failure ward rounds and we talked together. There wasn't just a note that we tried to interpret the writing, and if you've ever tried to read Niall Mahan's writing, good luck. and it wasn't, it was a full-on discussions, and there's often, the benefit of just talking face to face is so far beyond a very nice note and a prescription of medicines. So they were there every day. And we had an advanced heart failure patient meeting every week where we discussed all patients who were being considered for these advanced therapies. And so the palliative care consultant came around, met the patient initially on the ward round, and then organised a time that suited both patient and palliative care consultant to come back and talk about, well, what do you understand about what's going on? What do you feel, you know, is the information that you've been told good enough? How do you feel about the possibility that something bad will go wrong? And then help them make the decisions about where we were going. They also assisted in the serious psychosocial issues that, as cardiologists, we're generally not very good at. And they had one attending and a fellow in training. And they just did it because it fitted with the WHO recommendation that they be involved early in the course of illness in conjunction with other therapies intended to prolong life. So how can we replicate this? So it's very difficult to do. Karen and the people in the Mater have done a very good job at forming an alliance for patients at those stages of treatment, but it's more difficult in centres where we don't have advanced therapies. There's a scarcity of resources. There are very few of us who are primarily heart failure trained, but oftentimes we're not cognizant even of the patient decline. We see the patient in the outpatient clinic and we're not really looking at more subtle markers that patients are declining, such as fatigue, anorexia, cachexia. So what we have decided to do in Vincent's when we move there is to have monthly meetings, hopefully, with our palliative care teams where we'll actually discuss patients in advance, so that people who we see that are declining, we'll know about them in advance, and palliative care can come see them prior to the terminal hospitalisation. It does need real collaboration, and that requires time and investment, so you do need somebody who's interested in it. And it does mean all members of the team need to be thinking and working towards the same goal, which is patient well-being, which is sometimes overlooked in our busy clinics. So thank you.